So first, I'm just going to introduce Dutch just in a few slides, if those of you who are new. We have two types of collection with the Dutch test. We have the dried urine, of course, and our filter paper looks like that. You do a dried urine collection with a Dutch Complete and as part of a Dutch Plus. The other kind of collection we have are the salivette swabs, which are the ones on the left. The reason we went with the swabs is that they're easier to collect. You can pop it into your mouth, get it wet, stick it back in the tube. We use them specifically for the cortisol awakening response in our Dutch Plus.
Sorry,
you don't have to.
Can you share the slides, please? We can't see them.
They are shown. They're shared.
I confirm we can see them.
So people see them, so
okay.
It sounds like most people are seeing them.
Perfect. Okay, so with the salivette swabs, there's no spitting, passive drooling. It's great for those who have dry mouth, and it's predominantly used in research. And like I said, Dutch uses the swabs as opposed to the tubes. So is there research regarding dried urine? We get this question quite a bit from a lot of people, and there was in 2019. It was published where they looked at dried urine testing for estradiol and progesterone and compared it to serum estradiol and progesterone and found that it was a really good correlation. We are hoping to have data published this year, well, in theory, 2020, but maybe it'll be 2021 given the current situation, looking at cortisol. So we are trying to get our cortisol and many other studies published as well. When you're choosing the right test, like I said, we do have the Dutch Complete. These are the 4 urine collections done throughout the day. We do have the 5th overnight collection for insomnia, which is really great right now because I happen to currently wake up at 3 in the morning, which is lovely. We look at sex hormones and metabolites, cortisol, cortisone, metabolites, and the Patterne. And of course, we do some of the organic acids that were mentioned, but we are not an organic acid company. We don't run a lot. The Dutch Plus is everything I said, plus we do the 4 dried urine samples, plus we do the 5 saliva swab samples, looking specifically at the cortisol awakening response. And we have an extra overnight sample for, again, those people who struggle with insomnia and wake up at 3 in the morning like me and want to collect and see what their cortisol is doing. So the Dutch Plus is much more comprehensive collection. So you collect more data points and then you get more information to help your patient care. So it's definitely a more comprehensive test, a little trickier to collect, but more information. And just like Catherine said, this is included with all our Dutch Complete and our Dutch Plus. We do look at a B12, 2 B6 markers, a glutathione marker, a dopamine, norepinephrine, epinephrine, melatonin, and an oxidative stress marker. So we do look at that snapshot as they all relate to hormones and cortisol. So let's dive right into our pearls and patterns around the Dutch test. So first things first, if somebody says I'm tired but my cortisol is normal, I don't understand. Why wouldn't my cortisol be low if I'm so tired? This is your general reminder that, cortisol is not the only reason for fatigue. You have to check all of the other causes. And we absolutely will see this. We'll see people who have a perfectly normal cortisol response, and yet they're extremely fatigued. And so it's just just a reminder that you have to look elsewhere. What does the waking cortisol point reflect? So the waking cortisol point reflects that all the cortisol that was made all through the night, put into the bladder, and then comes out through the kidney. This is different from a saliva test. The waking saliva test, just like a waking blood draw, reflects the cortisol right in that moment. It's different from urine. So urine is the overnight. So all that urine overnight. So in this example, the circled in orange, the waking point is actually all the cortisol through the night. So in this example, the patient reports difficulty staying asleep. And the reason is they make a lot of cortisol through the night. It goes into the bladder and shows up in the morning on our test. So it's not so much an insomnia sample, but it is a really good indicator of what's happening broadly through the night. Now you still have to figure out why. You still have to address, is it their stress? Is it their sleeping habits? Do they snore? Do they have sleep apnea? Is it a blood sugar insulin issue? Did they drink alcohol before bed? Do they have worms or parasites that are active at night? Are they inflamed? Do they have an infection? You still have to figure out the why, but we can at least tell you cortisol's high through the night. So speaking of high cortisol in the morning and through the night, how can cortisol cause insomnia and AM depression? So this is a patient who had severe morning depression. It's known as melancholic depression, especially when it occurs in the morning. On her Dutch test, her Dutch showed a very high waking and then a very high morning point, and then it dropped down from there. So it turns out when the waking point is high, like I said, it reflects the cortisol through the night, and that's likely suppressing her melatonin as well, causing her to feel fight or flight and increasing her insomnia. But remember that elevated cortisol can divert tryptophan away from serotonin and push it down the kynurenine pathway. Now, if you're new to that theory, if you're not sure what I'm talking about, here's a graph. So tryptophan can go two directions. Tryptophan can go to serotonin, or tryptophan can go to kynurenine. And so when only 5%-ish goes to the serotonin, and the rest 95% goes to the kynurenine pathway. So, and we know serotonin goes on to make melatonin, and it makes the organic acid 5-HIAA, while kynurenine makes NAD, right? Very important for your sirtuins, very important for your mitochondria. That's why the 95% goes that way. It's really important for human health. Now, excess cortisol, excess estradiol, inflammation, and LPS, lipopolysaccharide, LPS, will divert tryptophan away from serotonin and push it down the kynurenine pathway. And when you get pushed down the kynurenine pathway, you have less serotonin. So you may go from 5% to 4%, 4% to 3%. And that can affect how you feel in the morning. So when somebody says, I wake up with depression, but it does tend to get better through the day, then that's when we start to think that it could, in this case, in this example, it's cortisol. But of course, we know it can be due to other reasons like high estrogens, right? LPS, inflammation. So you want to determine the possible causes of why they have high through the night cortisol. You want to evaluate their actual sleeping habits, who's in bed with them, kids, dogs, cats, the partner, like what's happening. They want to, of course, adopt a healthy sleep routine. They want to focus on all your products that calm before bed. You're looking at phosphatidylserine, right? All your calming herbs, your calming nutrients, magnesium, L-theanine, things like that. And you could consider serotonin support first thing in the morning to help with the creation of serotonin. So as an example, you could consider 5-HTP. You do have to be careful if they're on antidepressants. And you do have to be careful because remember, to make serotonin and to make dopamine requires the same enzyme. And so you don't want to deplete dopamine in your quest to raise serotonin. So always keep dopamine in mind when you're working with serotonin and vice versa. So what's inflammation? I keep talking about inflammation. We get asked this all the time. What does inflammation look like? So on the Dutch test specifically, inflammation looks like 5-alpha reductase that's upregulated. It looks like aromatase that's upregulated. So the conversion of testosterone and androstenedione into estrogen is high. They'll have higher estrogens, lower androgens. DHEA is lower compared to the metabolites, and I'll show you an example of what I mean. What happens is inflammation lowers sulfation, right? The S on DHEA requires sulfation. Well, inflammation blocks that. This part will be low. Estrogen will start to favor the 4 pathway or the 16 pathway. You can watch my prior webinar to learn more about that. You'll have elevated cortisol metabolism. You'll have elevated free cortisol, right? Cortisol's anti-inflammatory to a point. So it's trying to put the inflammation out. They will favor, on page 5, they will favor the THF, which is cortisol. That means they have an upregulated 11-beta HSD1. So on the Dutch test, we show you which one they're favoring. They're THE or THF. THF means they're favoring more cortisol, which makes sense. They're trying to put out the fire, protect against the inflammation. On the organic acid page, they'll have elevated kynurenate. They will have low or elevated pyroglutamate, which of course has a lot to do with glutathione. And they could potentially have an elevated 8-OHDG. That's a DNA damage marker. So if the inflammation is affecting the DNA, then it could raise the 8-OH-DG marker. So we want to be careful with that. So this is what it looks, this is acute inflammation in cortisol. We had a practitioner who called me and had results that look very, very similar to this. And he said, my patient is a very calm man. There is no way his cortisol looks like this. I think Dutch got it wrong. Can you repeat the test? So I pulled up the result. I pulled up the result of the patient, and the guy wrote on his form that he had broken his arm the day before and still collected his Dutch test the next day. So this is him the day after he broke his arm and ended up in the emergency room. So it just goes to show that this is an acute inflammatory response. This is totally normal for a guy who broke his arm. But you may see something like this with somebody who is acutely ill or acutely fighting an infection or has, hurt themselves in some way. So be aware when people collect their test results. I talk about inflammation and DHEA. So this is the DHEA pattern where the DHEAS is low, but the androsterone is high, and the etiocalanolone is in range. So you can see on that side, everything's high. So in this case, these are the DHEA metabolites. Etiocalanolone and androsterone are the DHEA metabolites. So that tells me that they make plenty of DHEA, they just don't sulfate, right? So DHEA is being made, but it's not being sulfated. It is, and what's happening is that it's moving downstream. So the DHEA is just moving downstream, and in this case, because it's inflammation, we know it's inflammation, it's choosing the 5-alpha pathway, so androsterone. And again, that now can lead to things like acne and hair growth in places we don't want as women, male pattern baldness, prostate issues in men. So that's what DHEA can do. Inflammation on the organic acid test looks like this. So there's kynurenine. Kynurenine is above range. There's pyroglutamate, which is a glutathione marker. It's, in this case, below range, needing glutathione. And then at the very, very bottom is 8-OHDG. It's at the high end of range. Hey, Kathleen, can you mute yourself? Because everyone can hear you. And I can tell that you're on. There you go. Thanks. So let's dive into the 4 cortisol patterns. We're going to look at the free and metabolized cortisols. And there's 4 patterns. There's 4 main patterns when it comes to the Dutch test. So why do we want to know the cortisol metabolites? Why does Dutch find this really important compared to like saliva or blood testing? So metabolized cortisol represents about 80% of the total cortisol production. So it gives us a really good idea of if the body is able to make cortisol in the first place. Because the free cortisol just tells you what's free and available, but it doesn't actually tell you if the body's capable of making it and what it does with it. So that's why we like the metabolized cortisol. It helps complete the picture. So we use that free, though, to assess how much is active and available and can bind to receptors, turn them on, do the things. And we want to assess the circadian rhythm because we want to know that they're high in the morning, like they should be, and then they're low at night so that they can fall asleep. And when the free and the metabolized cortisol are the same, they point the same direction, it's really confirmatory of what's happening in the HPA axis. But when they point in opposite directions, then it tells a different story, and I'm going to show you those patterns. So of course, pattern number 1 is high. Everything's elevated, high free, high metabolized. And we know that because everything's elevated, they have a high output of cortisol. This person is making, producing, and experiencing a whole lot of high free cortisol and a high production of cortisol. And so the treatment, of course, is to figure out why is the HPA axis so fired up and calm it down. Address the cause and calm it down. So this is pattern number 1. This one's very self-explanatory, as is this one, because what happens is over time, high cortisol can result in low cortisol. There's a negative feedback loop. So with this feedback loop, what happens is your cortisol goes up to the brain and says, we have a lot of cortisol, and the hypothalamus says, okay, I will make less. So does the pituitary, and it goes down and cortisol drops down. So if your patient has low cortisol, keep in mind they might have had high cortisol, but maybe months ago or, you know, a year ago, and now the feedback loop has kicked in and they're quite low. So this is pattern 2. They have low free and low metabolized cortisol. And because everything's low, we know that it starts at the brain. The brain is not communicating to the adrenals as much as it should to make cortisol. Now, this is different from Addison's disease. Addison's disease is the autoimmune disease where the adrenals actually don't make much cortisol. Just like in pattern 1, that's different than Cushing's disease. Cushing's disease is, or syndrome, is an excessive amount of cortisol, often due to a tumor, but potentially from supplementation. So if we take those off the table and we just look at the patterns, then this one in particular, we start at the brain, and we know the brain is not telling the adrenals to make cortisol. So you're going to address the cause, you're going to start with the brain, and you're going to help support cortisol production. That leads us to patterns 3 and 4, where the cortisol dials don't match. They face opposite directions. And so this tells us that cortisol metabolism or clearance is a problem, but it'll tell you where to look. So let's look at pattern 3, where the cortisol, the free cortisol, what's active, what's available, is high, but the metabolized is low. So basically the dials are facing each other when you're looking at your own Dutch test or the Dutch test of your client. What this tells me is that the cortisol clearance through the liver is slow. It's sluggish. As a result, free cortisol can't get metabolized, so it's coming through the kidneys as free. It's still free because it can't get metabolized. So it is really elevated. It's really elevated floating around. So on a Dutch test, it will look like this. The most absolute common reason for this is hypothyroidism. When you have hypothyroidism, it slows everything down, including the metabolism of cortisol. And as a result, the free increases for a while, and then eventually it will decrease. Other reasons, if it's not a thyroid problem, poor liver function and anorexia. Now, unfortunately, there is not a lot of research into anorexia. I've had people ask me, well, how long and how many years? And what if they had it as a teenager, but they don't have it now? Unfortunately, everybody's different, and it depends on the enzymes in your liver. So I have women who have a long-standing history of some disordered eating, and their pattern looks just like this. They started in their teens, and they're full adults, and they still struggle. I have other women that were anorexic in their teens or 20s and recovered, and now they're in maybe their 30s or 40s, and their adrenals look great. It didn't affect them at all. And I have others who were anorexic young, and still to this day, it has affected their liver. So there's no absolute. There's no absolute when it comes to that. But I will say, always ask your clients about a history of, disordered eating, but hypothyroidism. And it doesn't have to be outright hypothyroidism. It can be subtle hypothyroidism, right? It can be very subclinical hypothyroidism. Now, pattern 4 is the opposite. Pattern 4 is when you have very high metabolized cortisol and low free cortisol. And what this means, this is when your body is making tons and tons and tons and tons of cortisol, and you're processing it, you're metabolizing it as fast as possible. So there's very little time for your free cortisol to be left to float around. So it's quite low. So with this one, your most common reasons are obesity, believe it or not. Adipose tissue does a real number on cortisol. Hyperthyroidism, we see this often, we see it with Graves and true hyperthyroidism, but even over medication or over supplementation. So a lot of people believe that they're going to just give their hypothyroid patients lots of medication. They'll give them lots of thyroid glandulars, and then they push them into a hyperthyroid state. And we will see it on the Dutch test. Now, again, Dutch does not look at thyroid markers. We don't test TSH, T4, T3 antibodies. We don't do that. You'll still have to do that through different serum testing. but we do see these patterns over and over and over again. And of course, so many people get their blood tested that we put it together, and it's in the research. We see it in the it's been shown in the research. Other reasons possible with long-term stress as opposed to short-term stress, and the research is mixed, but those with chronic fatigue tend to have an upregulated clearance of cortisol, leaving their free cortisol very low. Not everyone, but enough so that there is some research around it. So your treatment is to address the cause and support the HPA axis without necessarily stimulating more cortisol production. So in these cases, I wouldn't use like adrenal glandular or adrenal cortex. I wouldn't necessarily think to use high doses of licorice, right? If it's hyperthyroidism, I would just address the hyperthyroid, knowing the adrenals will correct themselves. All right, speaking of thyroid, I want to show you why in the research and how thyroid directly impacts cortisol. So as someone becomes more hypothyroid, so the T4 goes down, their cortisol metabolism clearance decreases as well. Now on the flip side, as someone becomes more hyperthyroid, so their T4 goes up, right? Their TSH goes down, then their cortisol metabolites start to go up as well. So they parallel each other. Slow or fast, it's the same thing with your cortisol metabolites. So the Dutch test can really give you some direction as to maybe why or what's going on with the thyroid, how your supplementation is working, how their medication is working. So we know that thyroid directly impacts metabolism. So definitely in these cases, I would address the thyroid first or address the thyroid and the HPA axis at the same time. When it shows up on the Dutch test as these patterns and you know they have a thyroid problem, it's the thyroid impacting the cortisol more than the cortisol impacting the thyroid. And I know we get taught all the time, treat the adrenals first, treat the HPA axis first for the thyroid. When you see these patterns though, it's actually the thyroid exerting stronger force on the HPA axis. So you want to support them both at the same time. And there's some citations for that if you're curious. So the metabolized cortisol helps confirm or tell a story, like a thyroid story, about your patient's HPA axis dysfunction. So that's why Dutch has added it in, because it just helps you find more out about your patient. So let's go over a case. This is a three-part case. This is a same woman as she goes through the years to give you an example of how I would think about it and a whole lot more pearls and patterns. So we're going to start off. She's 35 years old. She has high stress, insomnia, depression, anxiety. Oh, sorry, I should have, everything's in American numbers, but I do have reference ranges as we go through, so I apologize. So she's gained 20 pounds in a year. She has moderate PMS. She has heavy periods, menorrhagia, and she's experiencing jawline acne. So this does not sound fun, right? No woman wants to have depression, anxiety, weight gain, PMS, heavy periods, and acne. This is no fun. So she's a lawyer, high stress job, working to make partner in her firm. She's married with 3 kids. She's 4-year-old, 6-year-old twins. She eats on the run. She skips meals. She binge eats. She will often stay up late, right? She gets the kids to bed, and then she has a glass of wine and continues to work because the kids are asleep and now the house is quiet, you know, and she and her husband can get work done. Now, as a result, she can't fall asleep. She often wakes stressed and anxious. She's been struggling with depression the last few years, especially in the morning. We just learned about morning depression. Sometimes she dreads getting ready for work, and her cycles are regular, but her menses are getting a lot heavier. Her PMS, like I said, is more pronounced, and her jawline acne, which she's had since she's a teenager, is now getting worse. This is like a pretty typical woman, right? We see these clients all the time, all the time. Here are her adrenal results. So we have cortisol on the left, cortisone on the right. So as you can see, everything's red. I mean, everything's red. She's fired up. She's in fight or flight. She's stressed out. She's, she's a lawyer, in a very stressful law firm with 3 kids, and she's not sleeping. She's not taking care of herself. Like, this is not surprising. This is not surprising. So she's pattern 1, right? She's pattern 1. She's high metabolized. She's leaning towards cortisone, which is DHEA. Oh, you know what? I didn't talk about the leaning stuff. So when I don't think I did. Oh, I think I do in a minute. Hold on. I'll come back to this. Now I can't remember because I have so many fun slides. I forgot what's on the next slide. She has high free cortisol and free cortisone. She has a high cortisol awakening response, which I will go back and you can see when she starts out her day, her on the left side, on the cortisol side, on the left side, her waking point is high. Her 30 minutes later point is at the top. It's the top of the peak, and then she continues to stay high. That's an elevated cortisol awakening response. And then she has high PM cortisol. So her last point is high. So she's, stressed out before going to bed. So high metabolized cortisol is due to stress. Is it due to she's put on weight? Is it possible inflammation? Is it glucose and insulin because she's not eating? Then she's eating and she's, drinking lots of wine. Here's where I say it. So she's leaning towards cortisone metabolites, DHE. So when the cortisone and cortisol are dictated by an enzyme called 11-beta HSD. HSD1 pushes you to cortisol. It turns everything on. HSD2 pushes you to cortisone, turns everything off. When the body is trying to turn her to cortisone, it means her body is trying to deactivate all that cortisol as best it can to protect itself. Because cortisol can be really damaging, as you know. Cortisol can be really damaging specifically at the mineralocorticoid receptors. That's where like aldosterone binds. Your mineralocorticoid receptors are really, you have a lot of them in the kidney, in the intestines, in the saliva gland, in the sweat glands. And so the body's trying to protect itself. And in her case, it's doing the best it can by trying to convert to cortisone, but she's just making way too much cortisol. So she has high free cortisol overall. We know that's worsening obesity. It's worsening her mood. We talked about depression earlier and how it reduces serotonin with high cortisol in the morning. It's causing insomnia and it's affecting her hormones. Her high CAR, anticipatory stress. She's a lawyer. She dreads going to work. She has blood sugar issues already, causes morning depression and anxiety. And of course, that high PM cortisol, she's working at night, she's drinking alcohol, maybe she skips dinner. We know this worsens insomnia and can worsen mood. So what I did was just break it down and then plug in all of her symptoms and where they fit so you can know how to address it. So if we look at this graph, the owner of Dutch created this graph as a better model for how how cortisol goes up and down. And the reason for that is most traditional conventional doctors believe you either have Addison's or you have Cushing's and otherwise you're normal. And we're like, we know better. We, as functional practitioners, we know that's not always true, right? We know a lot can go wrong with the HPA axis. So it's more this blended model, right? The shaded model. So you can have Addison's at the far end and you can have Cushing's at the far end. But in her case, she's not normal. She's over on the right side with high cortisol, adaptive cortisol. So she's nowhere near normal, but she doesn't have Cushing's. So her other hormones, just to give you a snapshot, she has low luteal phase progesterone. She has relatively higher estrogen, so she's estrogen dominant. She has high DHEA with high 5-alpha reductase. Her fasting glucose is 99 in the US. That's at the high end of normal. 100 is the cutoff. Her fasting insulin is 13 it's a functionally high. In functional medicine, I would say in the US, most people wanted insulin below 8. Some say below 9, some say below 7, and she's at 13. Her thyroid is normal and her iron is normal despite the heavy periods and fatigue. It's not an iron issue and it's not a thyroid issue. So why is her progesterone low? Well, let's look at this. So glucocorticoids, so cortisol, norepinephrine, epinephrine will inhibit the pulses from the brain down to the pituitary. So GnRH goes down. Therefore, LH and FH go down, and therefore your estrogen and progesterone go down. Here's what's so cool, not for her, but for us as we geek out. So FSH, of course, is in the first part of the cycle, right? And FSH is what pulses for estrogen strongly, And then in the second half of the cycle, it doesn't pulse. Your estrogen is not as high. You still need it, but it's not as high. So FSH pulses are slower and lower. They're less than a pulse every 2 to 3 hours. Can you imagine? Every 2 to 3 hours, it's like pulse, and then it goes on break, and then 2 to 3 hours later, it's like pulse, and that stimulates FSH. Your LH, on the other hand, dominate in the second half. Women, right? The late follicular phase to get ovulation, and then we need LH to continue in the luteal phase because that's what tells your corpus luteum, your lutein cells, to make progesterone. They're faster and higher. Their amplitude is higher to stimulate LH. Your GnRH is higher. So cortisol can be potent enough just to dampen the LH because it's GnRH is higher. So now it's coming down. So LH goes down, and now you just miss out on progesterone. Or it could be strong enough that everything comes down, all the pulses come down, and now she loses out on both progesterone and estrogen. What we tend to see as practitioners, though, is that stress will reduce the GnRH that makes LH first, so she misses out on her progesterone. We see it all the time. Women get stressed out and they ovulate late. They don't ovulate at all. Their cycles get weird. Their PMS gets bad. Think about right now with everything going on right now. So many women are reporting irregular, erratic, abnormal cycles. LH gets affected first, I find, and then FSH second. Why else could her progesterone be low? Well, her insulin is functionally elevated. So insulin resistance, high insulin gain, which she's having, but having too high insulin in the body decreases sex hormone binding globulin, that's SHBG, and it causes your theca cells to get bigger. And so when you have low SHBG and bigger theca cells, you make more testosterone. Now, when you make more testosterone and your theca cells are bigger, you're not making estrogen like you should, and you get this, your follicular development stops. You don't get the progression like you should, and if you don't get that progression of the follicle, right, to be like mature and ready to ovulate, then you don't make progesterone. So insulin can absolutely cause her testosterone to go up and her progesterone to go down, and her insulin's not great. So lower progesterone, higher estrogen, PMS, menorrhagia, insomnia, and anxiety, and she has all of those symptoms. And so hormones are definitely at play. So why is her DHES high, and why does she have jawline acne? Well, the thing is, I love DHEAS. I love DHEA. DHEA is my favorite hormone by far. This is so important in the brain. It helps with BDNF, brain-derived neurotrophic factor. It helps neuronal growth. It acts like an antioxidant. It's anti-inflammatory. It's immunomodulatory. And where'd my sentence go? It protects against the, I'll fix that when I send you guys the slide. It protects against the effects of, I see, it's the second line. It protects against the neurotoxic effects of glucocorticoids in the brain. That's supposed to be one sentence. Sorry. So, yeah, like how cool is DHEA? It goes into your brain and like tries to protect the heck out of you. Her cortisol is high, so DHEA is trying to do that. But her problem is she has high 5-alpha reductase. And we know high 5-alpha reductase, when those dials are elevated, increases the androgenic acne risk, the cystic acne on the jawline. Now, some of you may be looking at these dials and thinking, well, those aren't Dutch dials. They will be. So these dials are dials that are probably going to come out in an upgraded report by the end of this year. So we went ahead and put them in the lecture just to start showing people what they might look like. Those are the reference ranges around the dials. But it's the same markers that we have in our test right now. So androsterone is high, which of course is the high 5-alpha side. Her 5-alpha reductase is leaning towards the high side, of course, and she has the symptoms. She has cystic acne. So where should you start with her? Now, obviously keep in mind, you have to meet her where she's at. She can't quit her job, and she can't get rid of her kids, which I'm sure when you talk to your stressed out clients, I'm sure sometimes you think that that's the advice that you want to give them. Quit your job, get rid of your kids, and run away. Or sometimes your clients will tell you that. They're like, I just want to run away. So find out, see what she's honestly willing to do and adjust. So we talked about diet and movement. avoiding the skipping foods binge cycle that is doing no justice to her waistline and no justice to her insulin or her cortisol. Remember to hydrate, because dehydration is a stressor to the body. I asked her to reduce her alcohol to 1 to 2 times a week max, eat more vegetables, walk more at the very least, and try to pick up strength training if she can fit it in her schedule. But at the very least, she just needs to move some, right? I have to meet her where she's at. There are 3 kids trying to be a lawyer. Focusing on sleep hygiene, wearing blue light blocking glasses while working at night, because she's going to work at night. I can't stop her, right? Like she's trying to be a partner in her law firm, so let's meet her where she's at. And I want her to drink a calming tea, like Tulsi, which is holy basil, or chamomile, something calming instead of alcohol while she's working, because I think that will help quite a bit. Am I going to freak out about her DHEA? Nope, absolutely not. I think her DHEA is being protective in her brain against cortisol. So I want her DHEA to do what it's doing naturally. But what I am going to do is work on her 5-alpha reductase. So 5-alpha reductase goes up if you genetically have an increased 5-alpha reductase enzyme. There are actually 5 enzymes for 5-alpha reductase, but she's had it since she was a teenager. It's possible it's genetic. You know, we could ask about family history and things like that. Regardless, it goes up with obesity, adipose tissue, she has gained weight, and it increases with insulin. It can also increase with inflammation, which, you know, she's not doing that hot either. So here are natural ways to reduce 5-alpha reductase: saw palmetto, stinging nettle root, pygeum, africanum, EGCG from green tea, and reishi mushroom. This applies to men as well. And in fact, a lot of products will say something prostate on them: prostate support, prostate this, prostate that. And as we know, she doesn't have a prostate. So just warn her, like, you know, I know she doesn't have a prostate. I just need the herbs inside. Now, reducing insulin, obviously focusing on diet and movement. Inositol is one of my favorites for reducing insulin. I use it a lot with my PCOS, my PCOS women. And berberine. Berberine has been shown to be as effective as the medication metformin or glucophage if done 500 milligram. TID is 3 times a day. Sorry about that. So 500 milligrams 3 times a day, basically 1 with each meal. Is how you do that for helping with insulin. Now, everything's a Band-Aid. We know what the issue is. The issue is her diet, her stress, her lack of sleep, right? Her alcohol, like her lifestyle is putting her in the situation. But we're doing the best we can with her lifestyle and using the supplements as Band-Aids. And that's okay for right now. So with her specifically, again, diet, movement, reducing the wine, enlisting more help from friends, family, higher paid help. You know, like she doesn't have to be a hero and do it all. On waking, look at things that are stress reducing, like L-theanine, and the L-theanine helps to reduce glutamate, the glutamate effect on the receptors. So it's calming without inducing drowsiness. Consider 5-HTP for a month and reevaluate. I want to be careful of her dopamine. And looking at adaptogens, so something with B vitamins, vitamin C, ashwagandha, eleutherococcus, rhodiola, stuff like that. I am careful of my rhodiola dose. I do find rhodiola can be very stimulating for some people, especially if they're already anxiety, insomnia prone. So if I'm going to use it as a mix, I make sure that it's definitely not the star herb in my mix. I focus more with ashwagandha or eleutherococcus, you know, something like that. While she's getting ready, eating some myo-inositol and magnesium can be really, really helpful for just stress, anxiety, insomnia, or excuse me, insulin. Her omega-3s, I want her to getting 3,000 milligrams of omega-3s. And in the morning, remember, she dreads going to work. She's anxious, she's depressed. So I want to stimulate her vagus nerve. So I'm like, look, I want you to gargle. And I want, I didn't put a comma there. Sorry, gargle, comma, end showers in cooler water. And in the bathroom while you're getting ready, I want you to play your favorite music and sing. I want you to stimulate that vagus nerve, but make it simple and not overwhelming in the morning. In the evening, have her get blue light blocking glasses. Be mindful of her screen time. Like I said, she's going to work regardless. Drinking some kind of calming tea, not wine. And again, do another round of that inositol and magnesium. Do phosphatidylserine and do another L-theanine. Now, this seems like a lot, but I'm trying to get her sleeping and more energy, less depressed, less anxious quickly, so she's more ready to make lifestyle changes. She's ready to make lifestyle changes, but I want her to see the results quicker So she's more keen to stay with it, right? And then we're going to continue to check in and then retest in 3 months. So now, so my 35-year-old, the 35 and 45-year-old, the 35-year-old is a real case. And then what I've done is just projected her forward, 45 and 55 years old. So now these are made up cases, I will admit, but I want you to learn from these. So let's pretend now she's 45 years old. She's back in your office. She's very tired, especially after work. She has insomnia again. She's gaining weight again. She lost it. She has constipation and hair loss. What does that sound like? So she says, I felt good for the last few years, but it's changing again. I've made Patterne. It's stressful, but I use the L-theanine. My kids are now teenagers. Her periods are irregular. Now she's 45, much heavier. She skipped 3 months and then got it last week. She has some hot flashes and night sweats. She had lost all her weight, and now she's gained back most of it. She's not sleeping again, but she's not drinking wine, and she uses her blue light blocking glasses, and she can't figure out why she's not sleeping. And she's struggling with digestion. She has a bowel movement every other day. She is constipated. So if we look at her HPA axis, you can see the dials face opposite directions. Her metabolized cortisol faces to the left. Her free cortisol faces to the right. This is pattern 3. So low metabolized cortisol, she's leaning towards cortisol as opposed to cortisone. She has higher free cortisol and free cortisone. She has a high CAR, which I will go back and show you. So she continues to go up in the morning. So her waking plus 30 is in range, and then waking plus 60 is out of range. Still has that high CAR. Low afternoon and low bedtime cortisol. So if we go back, cortisol is not why she has insomnia. It was when she was 35. It's not now. So if we evaluate each thing, low metabolized cortisol, is it hypothyroidism? Kind of sounds like it, right? She has some of those symptoms. Leaning towards more cortisol metabolites, high stress, cortisol, and hypothyroidism can cause this, can cause that enzyme to be upregulated. She has high CAR again, so stress. She's made Patterne in her firm. She has teenagers. Is it blood sugar? And then she has low afternoon and bedtime cortisol. So circadian dysregulation, is it stress? Is it the feedback loop? You know, what's going on in her lifestyle? So now if we go back to this chart, her, she has higher end cortisol in the morning and then lower end which she gets through the evening. So she's not Addison, she's not Cushing's, but she's not normal, right? She's not normal and she does not have a normal pattern. Her hormones, she is below luteal range progesterone levels again. She has relatively higher estrogen levels again. Now, thankfully, her DHEA and her 5-alpha reductase are good. She doesn't report acne. And her fasting glucose and her insulin are within normal limits. So now it's not DHEA, and now it's not glucose and insulin that's going on with her. So if we look at this graphical of how estrogen and progesterone move as a woman goes through premenopause, perimenopause, and postmenopause, if you follow my little arrow, she has now moved from premenopause at 35 years old to perimenopause at 45 years old. So she's moved over. Now, again, I apologize. These are in American numbers, but I have the ranges there. So her TSH is at the high end of the range. Her free T4 and free T3 are at the low end of the range. Thankfully, her antibodies are negative. Her complete blood count is normal. And her ferritin, which of course is iron storage, is right at the bottom. 15 is the cutoff and she's at 17. So we know she has subclinical hypothyroidism. She doesn't, on this test, have Hashimoto's, but we know antibodies are tricky. But she's subclinical hypothyroidism, and she is definitely really struggling with that iron. Why is her progesterone low? Well, unfortunately, now she's perimenopausal. And coupled with that is her thyroid function. And we know as the thyroid gets slower, it often causes anovulation in women. It will affect a woman's cycle. So she has 2 whammies against her to reduce her progesterone. So why does she have menorrhagia? Couple reasons. Why is her periods heavy? Her progesterone is low. Her thyroid is not great. We know when the thyroid slows down, it can cause menstrual bleeding to increase. And she's losing iron because she's having much heavier periods. And so now her ferritin, she's not outright anemic, but she could be, if this continues. So we want to make sure she's keeping her iron, and that will help a lot with energy. So as a reminder, the hypothyroid pattern, as someone becomes more hypothyroid, their cortisol metabolism and clearance decreases. So everything goes down, which is aligning with her picture. So where should you start? Well, we know her metabolized cortisol is probably thyroid. We know her CAR is likely stress and anxiety. She's still a lawyer, still has kids, still married. And then she has low afternoon and low bedtime cortisol, fatigue, which she reports, suboptimal thyroid function. Lots of her symptoms fall in the thyroid category. Her low progesterone is due to perimenopause, suboptimal thyroid. That's causing worse PMS, heavy periods, insomnia, and mood. We know that progesterone in women, when progesterone continues to break down into its metabolites, it forms allo, A-L-L-O. Allopregnanolone, goes up to the brain and supports the GABA receptor. It's very calming, GABA A receptor, very calming to the body, helps with insomnia, helps with anxiety. So as women lose out on progesterone, they can definitely feel more anxious and have worse sleep. The borderline low ferritin obviously causes fatigue, can affect as a result of her heavy periods, and can cause hair loss, just like thyroid can cause hair loss. So we're going to address the thyroid and the HPA axis together. So in her case, at this point, I know that I want to support both. So to give you an idea, this is just an example. You guys know a lot of thyroid support out there. So there are a lot of cofactors that have to do with thyroid, right? Zinc, iron, selenium, vitamin A, iodine, copper, tyrosine, ashwagandha, guggul, coleus, and thyroid glandulars. I use a lot of glandulars in practice. I'm a big fan of glandulars, but obviously all the cofactors are really important as well. So you would do some sort of mix, whatever you do and feel comfortable with, on supporting her thyroid, right? While continuing to address her lifestyle stuff. So thyroid support, if you chose medication, I just wanted to give you guys an idea of what medications are out there, although I'm sure you're quite familiar. You have the T4 only, the T3 only, the T4, T3 combinations, and of course you have desiccated thyroid. And so in her case though, I honestly would choose the natural route, because I don't think she needs the medication, but every practitioner is different, and I wanted to give you the options. So what would I do? Obviously go back over the diet, the movement, the hydration, and the help plan, because I want to make sure that's we know what the issue is. we know what the cause is, and so we're just supporting her as she's continuing to make changes. So doing thyroid nutrient support, like I said, some sort of blend of the cofactors in the glandulars. Continue to use the L-theanine when needed. Restart that adaptogen mix, and especially do it on waking and again at lunch, because we know she dips down at lunch. Temporarily, for the time being, I'm going to have her add in some iron until we can get her menorrhagia slowed down, so she's not losing it all the time. And of course, as her thyroid gets better, her digestion gets better, her absorption gets better, and then obviously looking at iron-rich foods, but making sure she can absorb the iron at the same time. And then for her, being 45 years old, another option you could do, if you can prescribe, is you could put her on oral progesterone at night. Now remember, she skipped her period for 3 months, and then she got her cycles back. So when you do hormones with a perimenopausal woman, that I do them one of two ways, and this is me personally, nothing set in stone, this is just me. If she has regular cycles, I do use her progesterone in the second half of her cycle. And if she's completely irregular and skipping cycles, then I have her do 6 nights on and 1 night off. I do believe I was taught to give the receptors a break. My compounding pharmacist taught me to give the receptors a break, and that's what I do. Other people do it completely different, but that is an option. Now, the reason for that is that oral progesterone, when it goes through first pass, that's where it breaks apart into allo, A-L-L-O. And allo, again, supports GABA, helps sleep, and helps anxiety. The progesterone creams don't help as much for insomnia and anxiety. So some women do notice a difference with cream, but the cream, because it doesn't go through first pass, then you don't get that benefit. So please remember, with her, do regular follow-up for the thyroid, for the ferritin, for the hormones, and for the cortisol, because now she's 55 years old, right? You've been in practice so long that you have seen her for 20 years. She's very tired. She's burned out. Unfortunately, her mother was dying and she was a caregiver. She feels many of her thyroid symptoms have been coming back, and she's worried as recall, memory is a problem. This is really common. We see women as they get into their late 40s, 50s, and 60s. Now, their parents, unfortunately, are getting ill. They're having to be caretakers. Their kids are entering college, or maybe even, depending when they had them, getting out of college, starting families of their own. And there's like her, she's still in her career. She's still working. So it's a lot. So she hasn't been on thyroid or iron support in a long time. Her lab work has been okay because you've been monitoring it. She says, I'm very tired all day long, and it's very concerning. She feels burned out. The law firm is growing. It's requiring a lot of her time. Her mother, unfortunately, passed away 6 months ago, and she was the main caregiver with some other family for help. This is very common. I had so many patients that ended up being caregivers as they hit their 50s and 60s, and it requires, if you've never been a caregiver before, it requires an exponential amount of physical and mental energy, and it just takes it takes a lot. Even though it's often what you want to do, you want to be the caregiver, it's exhausting on the body. Her daughter got married, which is requiring a lot of planning, and she said, I haven't had a menstrual cycle in 3 years, so she is completely menopausal. She is still doing the progesterone, which is very helpful, but she's having recall issues, vaginal dryness, and some general joint pain. She's losing her hair again, and now she's constipated. So we look at her HPA axis, everything is low. Her cortisol pattern is low. She does not have a nice, healthy cortisol awakening response. Her free cortisol is low. Her metabolized cortisol is low. So when we look at this, she is pattern number 2, right? Everything, at 35, it started out high, then it looked like a thyroid issue, and now everything is super, super low. So, with that low metabolized cortisol, is it from the feedback loop, depressing the HPA axis, right? She took care of her mom. She's still part of the law firm. Her daughter got married. Like these are big, major life events, huge major life events. Her CAR is low, cortisol awakening response. That increases her autoimmune risk. It increases inflammation because the cortisol can't be anti-inflammatory. Is that making her joint pain worse? Fatigue and low CAR reduces recall. So where does she fall on this graph? Now she's all the way over on the left side. Does she have Addison's? No, she doesn't have Addison's, but she's not normal. She's way on the left side. She's low cortisol, adaptive cortisol. So over time, like I said, that feedback loop of high cortisol when she was younger, and she probably had high cortisol planning her daughter's wedding and taking care of a dying mother while running a law firm, caused low cortisol. It's like I was saying, when you're working with clients and they have really low cortisol across the board, ask them what happened in the last couple of months or years, because you will be surprised by what they tell you. So here's that loop. The cortisol goes up to the brain, reduces CRH, down to the pituitary, reduces ACTH, and that reduces cortisol production. So her other hormones, just as an FYI, she has postmenopausal levels of estradiol, estrone, and estriol. She has lower levels of DHEA and testosterone. Her glucose and insulin are still normal. Her complete blood count is normal, and her ferritin is normal. She's not bleeding, so she's not losing iron. That fixed itself. So if we go back to our graphic where she was perimenopause, and now 10 years later, where does she fall? She falls there on the postmenopausal chart. So she's 3 years menopausal, or postmenopausal. She's 3 years postmenopausal. So now we look at her thyroid and we see, dang it, her thyroid was doing so well, and now it's not looking so great anymore. She's looking more hypothyroid, and now her TPO, thyroid peroxidase antibodies, are positive. So Hashimoto's, which she has probably had this whole time, right? It's maybe at low level or something, which is, how sort of antibodies work. But how does the cortisol awakening response affect autoimmune? Now, remember, a million things go into autoimmunity. It's not one thing. There's not one thing, right? It's a domino effect of a lot of things. But I'll show you the cool science behind how the cortisol awakening response affects autoimmune. So it's called glucocorticoids induced apoptosis in the thymocytes. What happens is, I'll make this really basic, but I have the science there of what the physiology of what happens. You're a T cell, right? You're a part of your immune system. You're a T cell. Your body makes you, and you are considered, you have to go through the thymus gland, not thyroid, but thymus, and you have to get tested to see if you were created accidentally autoimmune. So your T cell is formed, it goes to the thymus gland, and if you react to any of the tissue in the thymus gland, it's called central tolerance. If you react to the self peptide, do you react to self, then you must die, because the body doesn't want to put out a T cell that already is created to go after your own tissue. Now it gets pulled aside to die, apoptosis, right? And what kills it, what induces the apoptosis is the cortisol awakening response. So if you do not have a healthy spike in cortisol in the morning, if you don't go up in a nice, healthy manner, you're at a higher risk for autoimmunity development or autoimmune progression, because you need those T cells to die. The way I imagine it in my head is that the T cells that are supposed to die don't. They sneak out of the thymus gland and cause problems, especially if you have a lot of them. So by improving her cortisol awakening response, I will naturally improve, hopefully, her autoimmune response. Obviously, I know a lot goes into autoimmune. This is just one factor and how it relates to cortisol. What affects recall and memory? She has a few things. So the cortisol awakening response has a lot to do with recall and memory. Estrogen has a lot to do with recall and memory. And of course, thyroid has a lot to do with recall and memory. And she has all three. So with CAR and recall, the rise in cortisol, a normal, healthy rise in cortisol, helps free recall from the hippocampus. But as we know, if you have too much cortisol, you can actually, unfortunately, cause damage in the hippocampus, and that can affect memory as well. So think about when you're super, super, super stressed out, maybe your memory is not as good, and you feel like you've lost, like you can't find your keys, and you have to make notes more often, and you just can't remember anything. Like you forgot your best friend's birthday, and then your stress goes down, and it all comes back to you. Like now you can remember things, and you don't worry that you have dementia, and it's okay. But the opposite happens. If you don't have enough cortisol, if you don't have that healthy spike of cortisol awakening response, your free recall is challenged. So especially of previously learned texts and pictures. So for those of you watching this webinar, if you are thinking about it tomorrow, 24 hours or 48 hours from now, and you cannot remember for the life of you what I said, you might have a cortisol awakening response issue, and maybe you should test yourself, because it could be really helpful with free recall. So her CAR was high initially, right? She took care of her mother. She helped her daughter plan a wedding. She still runs a busy law firm. So it was affecting her memory, her hippocampus, and now her CAR is low, which is also affecting her hippocampus. You can't win either way. You can't win either way. This is why it's so important to be in balance, right? To be in balance. As far as estrogen goes, it's well known that estrogen is really helpful for the brain. And in here, I just have a really long quote where it talks about how postmenopausal women with low estradiol levels, they perform significantly worse on verbal memory tasks, worse on verbal fluency. Women who went into surgical menopause, so their ovaries were removed, but were treated with estradiol, maintained their verbal memory. But in women who went into surgical menopause, who weren't given estradiol, they were as bad as the women who, like somebody who's gone through menopause and not been treated with estradiol. So estradiol has a lot to do with cognition. And we know this, we know estradiol has a lot to do with bones, right? Bone health, heart health, brain health, skin health, all the things, longevity. And as women lose it as they get older, coupled with stress, coupled with cortisol, coupled with hypothyroidism, Hashimoto's, like this poor woman. So let's recap. We're almost done. Low metabolized cortisol, likely due to that feedback loop, because she took care of her mom. She helped her daughter get married. She's running a law firm. Thyroid probably plays a role. Her CAR is low. That's going to cause her to feel tired. It's going to worsen inflammation, especially maybe at joints, right? Because cortisol helps reduce inflammation. And it could put her at risk for autoimmune. And I have a note. I want to be mindful of the flat cortisol slope. So this is one thing I didn't talk about. When cortisol is flatter, and if it doesn't have a healthy spike up and fall down, but it's flatter like hers, you are at an increased risk for earlier mortality if you get breast cancer. So it's been shown that breast cancer and prostate cancer in men, if they have a flat cortisol slope, they are at a higher risk for dying earlier. So we want to get their cortisol to have a normal rhythm, higher in the morning, lower at night, low through the night, because they have found that the mortality is much better, and that's what we want. So with Hashimoto's, we know that several of her symptoms, right? Low estrogen, memory, joint pain, vaginal dryness, and mood. So what would you do? Let's start with her car. So let's start, for those of you who have watched me talk about the cortisol awakening response, you know that it always starts with the brain, always. So for her, again, reminding her to follow a strict circadian rhythm, up in the morning, down at night. Get her gut healthy, continue to work on her vagus nerve. Improve blood flow in the brain, so exercise, right back to the main stuff. Exercise, she doesn't smoke. These are my recommendations for everybody, not just her, but these are what I do for the brain. Normalizing blood sugar, hers is fine. Considering brain things, neurofeedback, biotuning, cranial sacral, energetic medicine, acupuncture, chiropractic, massage, lymphatic work on the upper back, shoulders, and neck. How many of you are watching this webinar right now and your shoulders are up at your ears? Pull your shoulders down. Pull your shoulders down, stretch out your neck. You're gonna hear popping and crackling, right? Get your blood flowing, because that's how your hormones communicate. They communicate through the circulatory system, and they get made in the brain and have to go down. Hyperbaric oxygen therapy. You could test for iron overload. She, of course, doesn't have this, but if somebody has a really elevated ferritin, I get concerned about iron deposits in places they should not be. And reducing EMF or cell phone exposure to the head. Here are brain supplements as an example. So Bacopa is a really good brain supplement, one of my favorites. Fish oil, which she's already on. PQQ, rosemary, just using rosemary, like smelling rosemary. So go out in your garden and use rosemary, use it when you cook. And smelling rosemary essential oil, like when you're studying or listening to webinars. It helps a lot with brain function. Ginkgo, cordyceps, and maca, all really supportive for the brain. Getting sun or full spectrum light exposure first thing on waking. I am a huge, huge, huge fan of when you wake up in the morning, open your blinds, open your drapes, buy a full spectrum light box, go outside, get 5 or 10 minutes of full spectrum light. That helps. Light is what entrains your master clock, your clock gene, C-L-O-C-K, your clock gene. Light entrains it, dark resets it. So don't joke around with your light and your dark. Take it seriously. So treatment plan to consider, find a good counselor, address the thyroid and autoimmune. I feel like this is a whole other lecture. Sorry, I have an hour. But there are plenty of lectures and webinars on this. You know what to do. Focusing on the car, because we are talking about the Dutch test. So going back to stimulating, more stimulating supportive adrenal support. So B vitamins, vitamin C, eleuthero. Now I'm going to use more rhodiola. I'm going to add in some licorice. Be careful though, licorice can increase blood pressure and decrease potassium. So I'm always mindful of licorice. And cordyceps, adding in Bacopa twice a day, having her continue on her restart or continue her omega-3 fatty acids. And I had her buy 2 full spectrum light boxes. You just buy them online. They're very inexpensive. And I want her to use it at home. So when she gets up in the morning to turn it on, and when she goes into the office to turn it on, to continue it on through lunch, because I want that full spectrum light to, really help her cortisol awakening response. And even though the cortisol awakening response is only in the morning, I understand that. I'm trying to support her HPA axis through the entire morning because she crashes in the afternoon. So would I do HRT, hormone replacement therapy, with her? Well, she's on progesterone. So I would absolutely consider, assuming, right, the risks are minimal and I'm doing imaging follow-up with her, I would absolutely consider HRT with her. Now, HRT is a broad topic, hormone replacement therapy. we're looking at DHEA, we're looking at testosterone, estrogen, progesterone. Those are all considered HRT. So some combination thereof, I would absolutely consider with her being 55 years old with those symptoms. But like I said, that's an entire, that itself is an entire separate lecture. And of course, HRT is by prescription. Unless you live in the United States, then you can get DHEA over the counter and you can get topical progesterone over the counter, which is crazy. And that concludes our talks. Thank you so much for listening, everyone, and hanging in there through 120 slides. If you have any questions, please, I mean, I know you're asking questions, but after the fact, if you think of questions, please feel free to email info@nordicgroup.eu. And Catherine, I will turn it back over to you.
Thank you, Carrie. This is this like storm of information that comes out. I've been answering lots of the questions on the side, and there are many of them. And some of them are perhaps even beyond the presentation and beyond the questions that we can have here. But one came up at the end here, like how long time, if a patient is taking melatonin, how long time should they wean off the melatonin before they actually can, if they do the test and they get a true picture of their own melatonin?
Oh, yeah, absolutely. 2 to 3 days. 2 to 3 days. Yep. So, yep.
And then we've had another question that comes a little bit like, if people are on HRT, progesterone cream or whatever, can you use the test?
Yes. Yep. You can absolutely use the test if you're on HRT. And there are instructions in the collection guide. There should be instructions on if you're on certain kinds of HRT, should you just stay on it? Should you stop it for a day? And so, but yes, absolutely, you can use it to monitor.
Excellent. And then being on HRT and interpreting the test result, depending on what type of HRT, is it dermal, is it pills, is
yep, vaginal, yep, the patch, injections, the pellet. Yeah. So that's why it would require a whole huge extra other lecture, because there are so many ways to administer HRT depending on the hormone, and they all act somewhat differently. Even topical estrogen and topical progesterone do not act the same in the body. You cannot compare them. And so even just knowing something like that, that's why it would require a separate lecture. But yes, there are multiple.
So for now, we will finish up here. Thank you very much. We had 200 participants listening live the whole way through. So I will quickly get the recording downloaded and get it uploaded to YouTube, so all those who didn't partake can get it, and also so that you who did partake can listen again, because I think we all need to listen again. Maybe a couple of times even. So, yeah, so look out in your mailbox for slides that I will get from Carrie and the recording. I did mention in some of the answers that I sent off, because a lot of people were asking in regards to when do you find out when they're ovulating and when should you collect and so on. And I mentioned either you can use your an Oura ring to evaluate temperature, or of course just tracking your temperature in general, or use an ovulation kit could be of relevance as well. And that does not come in our test kits, so that has to be purchased elsewhere. So, but I think in regards to the Oura ring, I got a special offer from them, so I think I will share a link with them to all of you, so you can have a look at that, because that's quite interesting to play around with as well, in order to understand both stress and sleep even further, and combining it with the information that you're getting from the Dutch test. That's a really, really cool pair to play around with, and in order to understand yourself. Yep. So I will put that exactly. But yeah, thank you everybody for staying with us, and hopefully see you next week, not with Carrie, but with some other superstar. We would like to get Carrie back because she is really, really a superstar. So, but let's see, keep writing to me for ideas, for lectures and so on, and maybe we can do it again. Or once all this isolation is over, person.
Yes, let's do that.
Thank you very much, everybody.
Thank you. Bye-bye.
Thank you so much. Bye.
Bye.